Welcome to our video on inborn errors of metabolism. Let's begin. In this lecture, we will discuss disorders of classic galactosemia and amino acid metabolism. Let's start with disorders of galactose metabolism. For classic galactosemia, we'll talk about its general features, clinical presentation, diagnosis, and management. Classic galactosemia is another autosomal recessive condition resulting from deficiency of galactose-1-phosphate uridyltransferase. Deficiency of this enzyme causes inability to convert galactose-1-phosphate to glucose-1-phosphate. Galactose-1-phosphate accumulates in the liver, disrupting its normal functions. Additionally, galactose concentration is increased in blood and urine, causing galactosemia and galactosuria, respectively. Excess galactose is converted to galactitol. Clinical features of a neonate with classic galactosemia include infantile cataracts due to galactitol-mediated osmotic lens damage, in addition to nonspecific GI symptoms like nausea and vomiting. This condition predisposes patients to E. coli sepsis, and this is commonly a tested point. Finally, these patients all have hepatomegaly and jaundice due to galactose-1-phosphate accumulation in the liver. These clinical features manifest soon after the neonate starts breastfeeding because breast milk contains lactose, which is a disaccharide of galactose and glucose. Classic galactosemia is more severe than galactokinase deficiency, which is another disorder of galactose metabolism. The main difference between these two conditions is that galactokinase deficiency is not accompanied by liver damage. Galactokinase normally converts galactose to galactose-1-phosphate. Therefore, galactose-1-phosphate does not accumulate in the liver in the setting of galactokinase deficiency. Here we see the infant with bilateral cataracts. Take a notice at the bilateral opacification of the lens. Classic galactosemia can be diagnosed with a newborn screening. Additionally, the lab findings will show increased bilirubin, aspartate aminotransferase, and alanine aminotransferase due to liver disease. Disrupted gluconeogenesis can result in hypoglycemia. Urinalysis typically reveals the reducing substance in the urine. Reducing substance in this case is urinary galactose. However, finding of the reduced substance in urine is not specific for classic galactosemia. One should also perform measurement of GALT enzyme activity in the red blood cells. DNA testing for GALT gene mutation is also available. Just like we discussed for galactokinase deficiency, management of classic galactosemia is avoidance of galactose and lactose in the diet. A 1-month-old girl is brought to the physician due to severe nausea and vomiting for 2 weeks. Her symptoms worsen every time she is breastfed. She was born at 37 weeks of gestation via cesarean delivery. The physical exam reveals hepatosplenomegaly, jaundice, and the bilateral opacification of the lens. Systemic infection with which microbe is likely to develop in this patient. This patient presents with severe nausea, vomiting, jaundice, hepatosplenomegaly, and the infantile cataracts, as evidenced by bilateral opacification of the lens. Her symptoms worsen every time she is breastfed. Breast milk contains lactose, a disaccharide composed of galactose and glucose. Therefore, this patient with severe symptoms most likely has classic galactosemia. The patients with galactosemia are at increased risk for E. coli sepsis. Let's move on to the disorders of amino acid metabolism. In this subsection, we will discuss phenylketonuria, homocystinuria, and cystinuria. Let's start with phenylketonuria. For phenylketonuria, we'll discuss general features, clinical presentation, diagnosis, and management. Phenylketonuria, or PKU, is an autosomal recessive condition. Classic phenylketonuria is caused by phenylalanine hydroxylase deficiency. Normally, phenylalanine hydroxylase converts phenylalanine to tyrosine. Since we have deficiency of this enzyme, tyrosine becomes an essential amino acid in phenylketonuria. Additionally, excess phenylalanine is metabolized to phenylketones, namely phenylacetate, phenyllactate, and phenylpyruvate. Additionally, patients have microcephaly and seizures. Clinical presentation of phenylketonuria includes intellectual disability due to deficiency of phenylalanine-derived neurotransmitters like dopamine. A pathognomonic finding for phenylketonuria is musty body odor due to accumulation of phenylketones. Finally, patients have fair skin due to decreased melanin production. Tyrosine is converted to melanin by tyrosinase. In phenylketonuria, we have insufficient tyrosine that results in insufficient melanin production. Screening for phenylketonuria occurs 2 to 3 days after birth, but not immediately. The reason is that maternal enzyme breaks down phenylalanine during fetal life. Therefore, phenylketonuria screening test may be false negative on the first day. Quantitative amino acid analysis will show increased phenylalanine and decreased tyrosine. We can also measure phenylketones in the blood or urine. Lastly, genetic testing is available but not always performed. Let's now discuss the management of phenylketonuria. The patient should increase tyrosine content and decrease phenylalanine content in their diet. Tetrahydrobiopterin should be supplemented as well. Tetrahydrobiopterin is the cofactor for phenylalanine hydroxylase. Therefore, by supplementing tetrahydrobiopterin, we will increase phenylalanine conversion to tyrosine. Additionally, patients should avoid aspartame, which is an artificial sweetener containing phenylalanine. A 3-day-old boy is evaluated for a tonic-clonic seizure. He was born at 41 weeks gestation via cesarean delivery. He has a musty body odor. The physical exam shows neonate with fair skin and hair and microcephaly. Which amino acid should be supplemented in this patient's diet? This patient presents with recent seizure, musty odor, and microcephaly. He also has fair skin and hair. All these findings point toward the diagnosis of phenylketonuria. As we discussed previously, phenylketonuria is an autosomal recessive disorder most commonly caused by deficiency of phenylalanine hydroxylase. Therefore, phenylalanine is no longer converted to tyrosine. This is why tyrosine becomes an essential amino acid, and it should be supplemented in this patient's diet. Let's move on to homocysteinuria. We'll talk about its general features, clinical presentation, diagnosis, and management. Homocysteinuria is an autosomal recessive disease causing homocysteine accumulation. There are several causes depending on the deficient enzyme. Let's discuss these enzymes in detail on the next slide. This is an illustration showing multiple pathways of homocysteine metabolism. The most common cause of homocysteinuria is cystathionine synthase deficiency. This enzyme normally converts homocysteine to cystathionine. Another potential cause of this disease is the decreased affinity of cystathionine synthase to pyridoxal phosphate. Methionine synthase deficiency can also result in homocysteinuria. This enzyme normally converts homocysteine to methionine. Finally, deficiency of methylene tetrahydrofolate reductase causes homocysteinuria. This enzyme normally converts 5,10-methylene tetrahydrofolate to 5-methyl tetrahydrofolate. Let's discuss clinical presentation of homocysteinuria. Homocysteinuria is characterized by osteoporosis. These patients all have marfanoid habitus with the features like tall stature, long wingspan, long arms, decreased upper body to lower body ratio. Homocysteinuria is characterized by downward or inward displacement of lens in contrast to Marfan syndrome, characterized by upward and outward dislocation of the lens. Additionally, patients with homocysteinuria have intellectual disability, while those with Marfan syndrome do not. High homocysteine levels make patients hypercoagulable, predisposing them to stroke and myocardial infarction. These patients might also present with megaloblastic anemia and joint hyperlaxity. A 10-year-old girl is brought to the physician by her mother for a follow-up visit after deep venous thrombosis 3 months ago. She has an intellectual disability. Physical exam reveals excessive joint flexibility, tall stature, and downward displacement of the lens. The physician suspected homocysteinuria. What are the similarities and differences in the clinical features of homocysteinuria and Marfan syndrome? This patient presents with hypercoagulability, evidenced by previous deep venous thrombosis. She also has excessive joint flexibility, tall stature, and downward displacement of lens. All these findings suggest homocysteinuria. Now, the question asks about similarities and differences in clinical features of homocysteinuria and Marfan syndrome. Let's discuss and answer with the help of the table on the next slide. Both homocysteinuria and Marfan syndrome are characterized by tall stature and pectus deformity, namely pectus excavatum or pectus carinatum. Pectus excavatum is inward indentation of sternum, while pectus carinatum is outward protrusion of the sternum. These findings are usually accompanied by joint hyperlaxity, arachnodactyly, which refers to abnormally long fingers, skin hyperelasticity, and scoliosis. Let's talk about distinguishing factors now. Homocysteinuria is an autosomal recessive disease, while Marfan syndrome is autosomal dominant condition. Patients with homocysteinuria commonly have intellectual disability, while patients with Marfan syndrome have normal intellect. Downward and inward lens dislocation is characteristic of homocysteinuria, and upward dislocation is commonly seen in Marfan syndrome. While homocysteinuria is characterized by thrombosis, Marfan syndrome is accompanied by aortic root dilation. Megaloblastic anemia and fair complexion are present in homocysteinuria, but not in Marfan syndrome. Here we see the patient with marfanoid habitus. Please take notice at his tall stature and long upper extremities. This is an image of the patient with homocystinuria. The bluish part surrounding the black circle is called iris, while the black circle itself is the pupil. Immediately behind the pupil we have the lens. Normally, the margins of the lens should not be visible through the pupil. However, in this image we see the upper margin of the lens because it is displaced downward and inward. Diagnosis of homocystinuria occurs via measurement of homocysteine in the urine or blood. Management of homocystinuria includes supplementation of B6, B9, and B12 to lower the homocysteine levels. Antiplatelet and anticoagulant medications should be given to prevent thrombotic complications like myocardial infarction and stroke. Now we'll move on to cystinuria. Cystinuria is an autosomal recessive defect leading to decreased absorption of cysteine, ornithine, lysine, and arginine. The first letters of these 4 amino acids create the word cola, mnemonic that you can use to remember the absorption defect in cystinuria. Patients with cystinuria have recurrent kidney stones from an early age. This is because the cysteine moieties coalesce in the urine, forming crystals and the kidney stones. In order to diagnose cystinuria, we can perform urine microscopy. Urine microscopy typically shows hexagonal cysteine crystals. One can also perform urinary sodium cyanide nitroprusside test, or proton nuclear magnetic resonance spectroscopy of the urine. Sodium nitroprusside test gives urine the red-purple hue if the patient has cystinuria. Proton nuclear magnetic resonance spectroscopy of urine is another test used to confirm the diagnosis. This photomicrograph showing cysteine crystals in the urine. Please take notice that cysteine crystals are hexagonal in shape. Hexagonal crystals are pathognomonic for cystinuria. Management of cystinuria is based on the urine alkalization and chelating agents. Alkalinization of urine prevents cysteine crystal and storm formation. It can be performed with potassium citrate or acetazolamide. Chelating agents bind to cysteine and prevent cysteine crystal formation. Penicillamine is the most commonly used chelator in cystinuria. Let's conclude this lecture with a board-style question. A 15-year-old boy is brought to the physician on a follow-up visit after ST elevation myocardial infarction 4 weeks ago. He was diagnosed with intellectual disability at the age of 3. He's very tall with slender build, long fingers, and large wingspan. Vital signs include temperature of 36 degrees Celsius, blood pressure of 125/70, and heart rate of 92. Respiratory rate of 14. Physical exam shows downward and inward lens displacement and severe kyphoscoliosis. Which of the following is the best next step in diagnosis of this patient? A. Measurement of serum homocysteine levels. B. DNA testing for FBN1 gene mutation. C. Urine sodium cyanide nitroprusside test. D. Measurement of serum B12 levels. This young patient presents with an early ST elevation myocardial infarction, intellectual disability, and marfanoid habitus, including long fingers, tall stature, and long wingspan. Additionally, the physical exam shows downward and inward lens displacement and severe kyphoscoliosis. All these findings suggest the diagnosis of homocystinuria. The best next step in the diagnosis of homocystinuria is a measurement of serum homocysteine levels. Therefore, the correct answer is option A. Let's discuss why other options are incorrect. Option B is incorrect because DNA testing for FBN1 gene mutation is used to diagnose Marfan syndrome rather than homocystinuria. Although these two conditions are similar, Marfan syndrome is not characterized by intellectual disability and myocardial infarction. Option C is incorrect because urine sodium cyanide nitroprusside test is used to diagnose cystinuria rather than homocystinuria. Finally, option D is incorrect because although the patient with homocystinuria should be supplemented with vitamin B12, measurement of serum B12 levels is not necessary for diagnosis. And that concludes our lecture on inborn errors of metabolism.